Now we're recording. All right. But you still remember what I said before, right? Okay. All right. The rest are related to cellular excitation. So therefore, here you have muscle weakness, muscle cramps, muscle twitching. These are all effects of hyperexcitation, meaning if it's low in the blood, then that means ratio wise, they're higher in the cells. Okay, so ratio wise, so that's why you'll have these effects. And that's it for low sodium. Okay, so now let's go to high sodium. What is the effect now on the body with high sodium levels? So it'll be the opposite. Patient therefore will be thirsty. Rate the temperature all the way here. All right, so very good. Select all and apply question for next week's quiz.
No, it's
Your favorite. Table 10-6. All right, so we'll have more details on potassium imbalances. Let me go to potassium now. Right, unlike sodium imbalances wherein the causes are and interventions are not really detailed, here in potassium, regardless of the cause, management is the same. So we will discuss not only signs and symptoms here, but also the management. Okay, so no matter what the cause is, so let's say it's from cancer, it's from cardiac or kidney problems, the interventions, not only the manifestations, but the interventions are already discussed here, okay, in chapter 10. So we'll discuss that here. And it will not be repeated on the other chapters, not anymore, because it's already finished here, chapter 10. So let's begin with signs and symptoms. Okay, so you'll notice here, because what's the normal range for potassium? 3.5 to 5 milliequivalents. So it's very narrow, correct? It's a very narrow balance that we need to maintain. Now keep in mind, unlike sodium, wherein it's very abundant, potassium, not so much. You can see the level, 3.5 to 5. And we don't really have any storage, no storage capacity, meaning we can't store potassium anywhere in the body. Plus, it's narrow range, so it's really important to maintain potassium intake. Good thing though that most things we eat have potassium. It's just a matter of whether they're high in potassium or low in potassium. We'll look at the sources shortly. Now, the only way we can have potassium in our body is therefore to eat or drink it. Again, eat or drink potassium, not potassium itself, but the food and beverages that contain potassium, right? And another fact we have to remember is, aside from that food and beverages are our only sources of potassium, the only way we get rid of potassium is through the kidneys. So the kidneys, 80% of our body's potassium is excreted through the kidneys. A small percentage is excreted through the GI tract and also through sweat, but 80% is excreted by the kidneys. So this therefore means that before you give any potassium supplement, whether it's oral or intravenously, what should you assess first before giving any potassium supplement? Kidney function. Make sure that this potassium that you're giving can exit the body. All right? Are we clear? All right. Manifestations are the following: fatigue. So name a body system that is not mentioned here. None, right? So all muscles here are affected, especially the cardiac muscles. Okay, so that tells you how important potassium is. Plus, since we know that this is only acquired through food and beverages, who are at risk for potassium imbalances? You have a patient who's NPO for whatever reason. Let's say for a procedure, or let's say they have GI issues, we're not feeding them. Are they at risk for potassium imbalances? What about people who are in nursing homes who are not eating? They're not NPO, but they're not eating. Okay? They refuse to eat, or they don't know that they need to eat, such as in stage 3 or stage 4 dementia. Those people develop what's called agnosia. Okay? They don't recognize things anymore. You put a plate of food in front of them, they don't know what it is. So if they don't know what it is, do they know what to do with it? No. Something that basic. Okay, so severe agnosia, inability to recognize, much less use whatever that object is. All right. I'll go back to this table later when we get to the other problem. Okay, so let's finish first. So we know sodium hypokalemia. These are the manifestations. Let's look at the interventions. Under For this quiz and exam, I won't ask you about the EKG changes yet. I don't think it's fair because we haven't finished module 8 yet. But for exam 3, since we will now, by that time, we will finish module 8 on dysrhythmias. So you'll be familiar with rhythms already at that point. So that will be on your third exam. Okay, so let's look at the interventions. So your potassium is low. So how do we fix it? We give potassium. There are two routes we can give potassium, only two. It's either oral or IV. There is no IM or sub-Q potassium administration. Okay, only oral, which can be either a tablet or a capsule or liquid. Okay, they're only oral or IV. IV, of course, will be IV. So for sources, these are the examples mentioned in the book. So most fruits, vegetables. For fruits, it's mostly citrus fruits. So anything that is citrus is very high in potassium. For vegetables, is potato a vegetable? It is, right? Yeah. So potato, in the potato, that's high, but it's mostly on the skin of the potato. Legumes, all legumes are high in potassium. Whole grains, milk, and meat. Didn't specify which meat, right? So all meats are high in potassium. So granting this, what problems could you see with people who are not eating hypokalemia? All right. So if the oral route, no, if we can't accomplish it through food and beverage, then it's time to give the supplement, right? So we give them tablets, capsules, or liquid preparations of potassium. Another fact here is salt substitutes. I think I mentioned this last week. I did, right? Okay, so salt substitutes contain potassium instead of sodium. So bear that in mind when your patients are on cardiac medications, for instance, or later today, after the break, we will discuss kidney failure. Now, there's really not much problems we have with oral potassium, okay? So as long as the patient takes it. The problem really is with IV potassium. Here are a few facts that we need to know. First, KCl or potassium acetate or potassium phosphate are alternates to potassium chloride, but most forms we give a potassium intravenously is through in the form of KCl, potassium chloride. But sometimes doctors will prescribe potassium acetate or potassium phosphate solutions. Now, priority. You will receive several orders here, especially if the hypokalemia is severe. So you'll have a series of orders. Question is, which order do you carry out first? Now, one of the orders you will receive is the need for cardiac monitoring, in addition to the oral and or IV potassium supplements. Which among them will you follow first? A, cardiac monitoring. B, the oral potassium. C, the IV potassium. Which one will you administer? Which order will you carry out first? Cardiac monitoring first. The rationale for that is it will take time for us to administer the medication. Okay, because you have to grab the bag. If it's IV, you choose IV. You have to grab the bag. You have to go get the tubing, pump, and then administer. That is if your patient has an IV access already. Do you follow? Now, does it take a long time to put on a cardiac monitor? So you only need to put 5 leads, attach them, turn the monitor on, and then that's it. So it takes less than 1 minute. So which one will you do first? Of course, the cardiac monitor. Another reason is if this patient does have arrhythmias and they are fatal, at least we can rescue the patient. We can treat the life-threatening arrhythmia. Okay, so we save the patient that way until we can correct the potassium imbalance. Any question on that? All right. Now, prevention, of course, is the best. We should not have had low potassium in the first place, but no, different circumstances. Some people do sustain hypokalemia, okay, for one reason or another. Let's go now to, so these are your prevention. I won't read it for you.
I have a question.
Yes,
What is the difference between the potassium acetate and potassium phosphate?
they are just differing in the, you know how molecular structures are? I won't go into that detail. You know how every molecule has a certain structure. Okay, that's all they come different in. Okay, so just the molecular structure of that drug. So let's say between potassium chloride and potassium acetate, because they all have potassium. It's just a matter of which did you mix it with. So KCl, of course, you mixed it with chloride, the other with acetate, the other with phosphate. Okay, so here are more examples, more specific examples of the food and beverages that have potassium. Trust me, you will not see bananas on my test questions. Okay, I'm tired of bananas. I don't like bananas, so you won't see bananas on my choices. But you will see melon. When I say citrus fruits, does everybody know what citrus fruits are? Examples of what are considered citrus? Anything that looks like lemon, grapefruit, oranges. Okay. Have you seen the ones that are in Asia? What's the name? No, like they're like giant grapefruits. No. Pomelo? Pomelo? Yeah, pomelo. Okay, so I'll just come up with what's found in your grocery stores, right? So here's the administration now. So oral, here's a first cues and warning. Can somebody read this? Thank you for volunteering. Miss Harnoor. Okay, very good. Okay, let's go to IB now. Now, the only, well, I should say only. We said it's only oral or IV, correct? Okay, so when we say IV potassium must always be diluted. Okay, they should be in at least 100 ml or more. The concentration should be about 1 MEQs of potassium chloride per 10 ml. So therefore, if you're giving 10, what is the diluent? Again, the concentration should be 1 milliequivalent per 10 ml of a solution. So therefore, if I have 10 mLs to give, what should be the dilution? 100. Okay, 1:10. Are we clear? So 1 milliequivalent should be in a 10 ml solution. So since the lowest potassium formulation you can give is 10, so therefore they will be in a what amount of bag? 100 ml bag. So 10 and 100. Okay, so it's never undiluted. Are we clear? No, sorry. It is given undiluted and IV push if you're executing somebody. So in the death row, when they say lethal injection, this is the lethal injection drug. Okay, we're not giving cyanide or no any poison to patients when we any death row inmate. Okay, that's not how we kill those patients. So when you're executed for whatever punishment it is, this is what we use to kill you. All right, we use potassium chloride. It's a peaceful death though, okay? Because you're sedated first, okay, you're paralyzed first, and then we give you a lethal dose, concentrated KCl. And there you go. Bye-bye. Okay, see you next time. Are we clear? So will we ever use undiluted potassium? No. Plus, there will never be nurses working in death row. The ones who administer it are doctors because it's against our. Have you seen the nurses pledge? Nurses pledge says do no harm, right? You will not knowingly or unknowingly administer any harmful substance. Is that consistent with that pledge when you're working in death row? No. So no nurses will be employed there, and they know. Okay, that's just against the nursing profession. Okay, so we do not participate in that. So as much as you'd like to, let's say, I'd like to do that. Okay, legally kill somebody. Okay, some people get a kick out of it, right? If you're some kind of psychopath, yeah, that would be a good, career choice, but unfortunately not for nurses. All right. So we know no IV push, so no concentrated IV infusions. They're always diluted. And during the infusion, again, if the patient, how much of the potassium in our body is excreted through the kidneys? 80%. So therefore, whenever you notice any decrease in kidney function, what are signs of decreased kidney function? We discussed some last week. So what are those two labs again that indicate kidney function? BU and creatinine. So what will happen to BU and creatinine when there is evidence which is proof that kidney function is decreasing? When they start increasing, okay? So or what happens to the urine output? Okay, starts decreasing less than 30 ml per hour or less than 0.5 mL per kilogram per hour. All right. So here are your warnings again. So never give IV push, never IM, and the limitation. Okay, so let's look at the limitation. Okay, I can't find it, but we never give more than 20 milliequivalents of potassium per hour. Now that's according to the textbook. Now in practice, we never give potassium chloride amounts of more than 10 milliequivalents per hour. If you see 20 on an exam question, that's also correct. But in practice, just because in all my years, I've never given any potassium higher than 10 milliequivalents per hour. All right, in practice. But on the textbook, 20 milliequivalents per hour is as far as you can go. as high as you can go. But again, what's happening in practice? Only 10 milliequivalents per hour. So let's say the patient is unconscious, the patient's in critical care, right? So can you give them anything by mouth? Obviously not. Okay, so let's say we have no feeding tube. So your only choice is IV, correct? So is it easy to correct low potassium levels? Let's say what's the lowest number, the lowest value? 3.5, correct? What if my value is 2.6 or 2.1? Is it easy to replace 2.1 if I can only give 10 milliequivalents or even 20 milliequivalents per hour intravenously? Is it easy? No, it'll take days. It won't take hours. It will take days to correct that potassium level if it's that low. So what is your priority until you can correct it? What intervention should you do since we're helpless? Again, A, cardiac monitoring. B, oral potassium. C, IV potassium. Still cardiac monitoring. All right. Any question? That's it for potassium replacement. Alrighty, last topic for before the break. What if the potassium is so high? Let's go back to table 10-7. Here are your manifestations. Between low and high, look at the only difference here is really, well, with the GI, it's opposite, right? In GI, you see here that in low potassium, there's decreased bowel motility. So you're expecting nausea, vomiting, and constipation, right? Here you have ileus, right? There's abdominal distension, all because there's less peristalsis. Here you have high peristalsis. Okay, so you still have abdominal distension, but then you could have diarrhea here, okay, and muscle cramps. Not only muscle cramps, but also abdominal cramps. Okay, but for muscle, this one says muscle weakness, which is the same here. There's also muscle weakness here, right? So you can't really use weakness as a differentiating manifestation because in both instances, whether it's high or low, there is muscle weakness. You do have differences in the ECG. Okay, so this one is tall peak T waves. Then you have here flat T waves. Okay, and again, not for exam 1 or the quizzes for exam before exam 1. Let's go to correction now. In correcting high potassium levels, we have so many other choices. Unlike in low potassium, the only way is to administer potassium, right? Oral or IV. Here in excess, we have different choices depending on how fast do you want to lower the potassium. Now, there are two ways to lower potassium. One set of interventions involve shifting the potassium, meaning let's take it out of the bloodstream, put it momentarily inside the cells. Are we clear? Because remember, we have 2 compartments. So when we say high potassium, where is it high in? Extracellularly or intracellularly? When we say high potassium, where is it? Extracellularly or intracellularly? Why extra? Right, because your blood sample was the basis for us knowing it, right? We drew blood, it was high, so therefore it's high outside the cell. It's high in the bloodstream. Okay, so now we know it's high. So there's 2 ways to tackle it. Just like replacing potassium, was it easy or hard to replace potassium? Hard. It's even harder lowering potassium. So you have 2 sets of interventions here, or of options. Either shift it, take it out of the bloodstream, not necessarily take it out of the body because that's harder. It's harder to remove it from the body completely. So if it's really low, doctors will order interventions to shift it, take it out of the bloodstream, put it inside the cells for 2 hours. So it buys you 2 hours of patient safety until we can eliminate it altogether. Again, Eliminating it is not very easy, okay, because we're dependent on kidney function, correct? But what if the patient comes in, because most of the causes here involve kidney function, meaning why did the potassium go high? Because the patient's kidneys are not working in the first place. And remember, 80% is excreted through the kidneys, but most causes involve kidney function, impaired kidney function. That's why the potassium levels rose. So in that case, therefore, is it easy or hard to eliminate it? Very hard to eliminate. So therefore, it's easier to shift it. Okay, so take it out of the bloodstream first, put it somewhere else, stash it, and then until we can totally eliminate it. So let's look at our choices. Okay, so in non-acute, meaning minor potassium imbalances, we can simply restrict it from the diet. Email. So just restrict it from the diet. All right. If this would be, let's say, 5.2, 5.3, it's just a minor elevation. Okay, so you can do that. As long as the patient doesn't have any symptoms. So let's say they have no cardiac manifestation, so it's okay, right? So the patient's tolerating that problem, you can restrict the diet. In moderate to severe, though, we have to do something. All right, so if it's moderate, we can afford to use the elimination of potassium options. Number one is administration orally or through an enema. Resins like SPS. SPS, those who work in hospitals, this is Kexalate. Okay, the brand is more popular, Kexalate, but FYI, you won't see Kexalate on the NCLEX. Why? They only use generic names. Okay, so forget all the brand names. They won't help you on the NCLEX. NCLEX only uses generic names. So generic name for Kexalate is SPS, sodium polystyrene sulfonate. So this is a light brown liquid. Okay, there's no pill here. So this is a liquid. It's about 60 ml, 2 ounces. So you give it through mouth by mouth. Okay, have the patient drink it, or if they won't drink it, give it through an enema. Okay, so you give it put it into an enema bag and then administer an enema. You know how to give an enema, right?
Yes.
What is an enema? Something that's not your friend, correct? Is that enema?
That's how patient for constipation.
Okay, very good. It's not your friend, right? Enema. Enemas are not our friend. Is she your friend or your enema? It's my enema. So that's how it works. So this one, of course, is through the GI tract, but does it really eliminate much potassium? Because remember, 80% through the kidneys, GI tract 20. So does this eliminate a lot? Not really. So can this cause diarrhea though? Yes, this can cause diarrhea, which is the idea, the whole idea. We want to eliminate potassium through the GI tract, and diarrhea causes hypokalemia. All right. Here's of course, there's always warnings, right? So if we had GI bleeding as a contraindication for oral, right? Potassium. So this one is also for SPS. So if there's paralytic ileus or any decrease in peristalsis, is it safe to give this? No. So that's a contraindication. Okay. The problem with SPS is not only does it only eliminate, a little bit of potassium, and that's how it works. It also takes 2 hours before it works. So if you give it now, when will the body start eliminating potassium? 2 hours. So it takes a while. So is this your first go-to when you need to eliminate or lower potassium right away? No, this is never an emergency option. Are we clear? So this option is for mild, moderate, or severe hypokalemia. Mild or maybe moderate. Okay, but again, this is not our first choice. It takes too long. All right, let's go to another option. So instead of SPS, this is a newer drug. We have Patiromer Sorbitex. Works the same as SPS, okay, there really no difference. So same here, so exchanges calcium for potassium in the intestine, so still works through the GI tract. But it's newer though. Instead of SPS, you have bacteremia. We also have Lokelma, which is not in your textbook. I forgot the name, but it says something like zirconium something. But since it's not in your textbook, then we'll stick with SPS and bacteremia. How about that? Okay. Okay, so for emergency, so therefore, is this mild, moderate, or severe hyperkalemia? It's severe. Okay, so dangerously elevated. Now we have to give IV calcium gluconate. Now this option does not eliminate potassium. So here, it antagonizes the effects of potassium, but does not reduce serum potassium concentration. So is this a life-saving intervention? Yes, but again, did it eliminate potassium? Not at all. It just simply antagonizes. So at least the effects of potassium on heart function is decreased. Are we clear? All right. Okay. Another is, of course, you put the patient on a cardiac monitor first, and we discussed that already. So this will be some of the orders you'll see. Okay, calcium gluconate. Okay, now don't be surprised. Will this likely be your only order? No, because remember, did this eliminate potassium at all? Did it shift the potassium? Not at all. It simply antagonized its effects. So potassium levels are still high. So you will expect other orders besides this. Are we clear? So I repeat, for high potassium problems, this will never be your only order. Are we clear? Okay, so this will simply save the patient's life. Okay, so that's just one intervention. What are the others? All right, here we go. Sodium bicarbonate. So what will this do? So when you give this IV push or through infusion, if you're lazy like I am, I hate pushing sodium bicarb because this is 50 ml. I mean, I have arthritis. I can't push 50 ml with these arthritic hands. So I will put it into a pump. Okay, I'll let the pump push it. Push it over 5 minutes, right? There's a machine that can do it for me. So why punish my pretty hands? Right. So what will this do? Shift potassium to the cells. Did it eliminate it? No. So therefore, will this be your only order? Not at all. So you need something to actually eliminate it. But will this work right away? Yes, as soon as you administer it, within 30 minutes, potassium levels will drop in the bloodstream. Because where did they go? Into the cells. So therefore, here, you see the effects of this will begin within 30 minutes. Okay, so this will buy you time. All right, what's the other administration? So sometimes you'll get them both. You'll get an order for sodium bicarb plus IV administration of regular insulin with dextrose. Now, these two cannot be separated. I repeat, these two cannot be separated. You can't give regular insulin IV only. You can't give dextrose solution only. They have to be given together. Why? What will be the effect here? Now, regular insulin will shift potassium also here, temporarily shift potassium into the cells. However, what will also insulin bring into the cells besides potassium? Glucose will also enter the cell. So what will happen to your glucose levels? Can I go hypoglycemic? Yes, so therefore, that's why. How is this option given? With dextrose, because you want to lower potassium, but since glucose will also drop because of insulin, now you have to give the dextrose. So that's the purpose of the dextrose here. Any question on this option? Very good, children. Others are, now there are options here that will eliminate it. Diuretics can be used. The problem with diuretic options is what will also drop? What will also diuretics drop.
So,
Fluids and also other electrolytes. I know in pharmacology, your instructor always talked about potassium with diuretics, correct?
Yeah.
But if you read the drug book, what else does it lower? Actually lowers all electrolytes, sodium, potassium, calcium, magnesium. It lowers everything. But of course, which one is most concerning? The potassium. All right, here are others. Albuterol can be also ordered. So beta-2 agonist. Again, side effect, however, if you choose the albuterol, side effects of any beta-2 agonist is tachycardia, just like epinephrine. So you give that via nebulizer. If the potassium level remains high, despite all these options we've given, the last choice is dialysis. So we will have to remember earlier, can we put in a non-tunnel dialysis catheter? And how long will that take to insert? 10 minutes, right? In 10 minutes it's in, we can start dialysis right away. Okay, so that's the other option. Any other question? So we have so many, right? So many options to decrease potassium. But again, that's why there's so many, because it's so hard to eliminate potassium. Because what again is the most common cause of high calcium in the blood? It usually involves some kidney problem. Okay, that's the number one cause. Patient go, it's easy though. So let's say you're dehydrated, right? So one of the consequences of dehydration is acute kidney injury. Then once you have acute kidney injury, what happens to kidney function now? Drops. Now what happens to potassium? Okay, all right. So that's it for sodium and potassium imbalances. Any question? Okay, take a break, come back 2:35.